Next, we move on to the next talk. Dr. Andy Mermod, and he is a medical director at the Swiss Physio Monchesas Clinic. His research interests include both surgical and medical glaucoma. And we welcome you to this surgical session on Glaucoma Subspecialty Day. And we look forward to your talk on penetrating and non-penetrating deep sclerectomy. Over to you, Dr. Andrew.
Thank you very much. Yeah, I was teaching for many years on non-penetrating deep sclerectomy, and this never really worked in Asia and in different places. Actually, if you have shallow chambers or if you have not a good follow-up for your patient, then it's much better to do a penetrating deep sclerectomy. So I'm going to start my conference with non-penetrating deep sclerectomy, and I will finish it with penetrating deep sclerectomy, where you don't need to do a goniopuncture, where you don't need to have the fear of iris incarceration. So in my hands, I really prefer to do a non-penetrating because I know that my patient, I can follow them very easily. They will come for follow-up visit. I can do the goniopuncture when they need. And if they are old people, they will not do physical effort. So the risk of iris incarceration is quite low. And see that these are the results. After 6 years, the mean pressure is 10 millimeters of mercury. I mean, going from 10 to 11 millimeters of mercury. This is really what we want for our advanced glaucoma cases. This is another study showing also, that is the Sponsel study, showing also pressure of 12 millimeters of mercury after 5 years of follow-up. And this is another study showing that if you compare deep sclerectomy and trabeculectomy, after 36 months, we have exactly the same pressure of 11.2 and 11.1 millimeters of mercury for both techniques. So they work really similarly. Now you would argue there are some studies showing that in deep sclerectomy the pressure is higher. And here are a few examples. You have the Lashkar study, pressure of 15.6. You have the Silino study, pressure 17.6. And the Kosobolis 15.9. So these are higher pressure, almost like MIGS that we discussed this morning, which are not very interesting if you have advanced glaucoma. The reason is why are those colleagues so higher pressure? Because I went to talk with them and they're not actually performing the right technique when they are doing the dissection. And let me now show you how you have to do the right dissection. This is okay, we start with a good exposure, and I put a track suture. Then I open the conjunctiva, usually at the limbus, to help to have a very posterior bleb, so I try to avoid a posterior incision. Then I manage to bring back the tenon. When the tenon is far posterior, I think it's important to have a good closure, so we bring back the tenon carefully to be able to avoid leaks postoperatively. Then we do minimally cauterization to have a clean site. I'm using mitomycin, at least in Switzerland. In Africa, I don't have, so I don't use. And interestingly, the results are not so bad, even in African patients. Then I'm starting your superficial flap. And this is important to do it quite big. It's at least 5 millimeters by 5 millimeters, so it's much bigger than the trabeculectomy you saw before. Usually in trab, we do 3 by 3. Here, in order to get a big intrascleral bleb, we are doing this big superficial flap. And the flap is very thin, should be about 1/3 of the scleral thickness, so to give you more chance to remove more sclera to create your intrascleral bleb. And this is, we are doing quite anteriorly the flap so that we can reach the Descemet membrane. The second flap should be a bit smaller, so the bleb will be watertight. I mean, the flap will be watertight on the side, and then we go to the end on the posterior part so that we will have that posterior part for the flow. Now here we go and can see down to the choroid to know exactly the maximal depths of the sclera, and then we are following that very deep layer, and so we will reach anteriorly, we will reach Schlemm's canal. Now you can see I'm opening on the side radially, and now this is Schlemm's canal. And Schlemm's canal should be exposed if you want to do a proper deep sclerectomy. And then you have to dissect between the sclera and the Descemet membrane. I mean, first you have the anterior trabeculum, and then more anteriorly you will find Descemet membrane. And by doing gently this pushing on the membrane, you will not penetrate it, and you will create that trabeculo-Descemet membrane, and you can see that the water is already flowing through. And then at the end you are going to cut the deep scleral flap. This volume you are removing will actually create an intrascleral volume that will be the intrascleral bleb. At the end of that, I like to remove the inner wall of Schlemm's canal using that special forceps, and that will remove some of the resistance of the outflow. We have to close that flap, and if you didn't penetrate, then you can just put 2 sutures untied. I mean, because you just want the flow going back, and then I'm using some viscoelastic to help to keep that space. And this is Ilaflow, which is reticulated hyaluronic acid. I'm also closing the wound with a running 8-0 Vicryl with a round body needle. So we are doing almost in every case more than 80% agoniopuncture, because with time the membrane gets thickened and then the flow will reduce and the pressure will go up from 10 to 15. Then we are doing the laser. Interestingly, consider when we did the laser, the pressure was up to 22. Right post-laser it was 12.5, so you have an immediate result, and 2 years later it was 11.7. So the laser is very easy to perform, but you need to have a laser. I know that I'm working in Africa, they don't have a laser, so that's why I don't do deep sclerectomy without penetrating it at the time of surgery. The advantages are, and the indication, are all kind of open-angle glaucoma. They can be primary open-angle glaucoma, but also secondary to pseudoexfoliation, to pigmentary glaucoma, or all kind of glaucoma. Even in pediatric cases, I do a deep sclerectomy to avoid the fibrosis of the subconjunctival space. I want to create an intrascleral bed, but I do an opening at time of surgery and a peripheral iridectomy, and this is penetrating deep sclerectomy. The main advantage, and you can see it on this scheme, is that you don't only get a subconjunctival bleb, but you also get intrascleral bleb under B, and you also get a subchoroidal bleb under C, because the thin layer, remaining layer of sclera is so thin that the water will actually go through and do a choroidal detachment, slightly choroidal detachment, and there is a bleb over there. And here I just want to show you some results on rabbits. If we do a deep sclerectomy in rabbits, it's not closing immediately, but slowly it will build up the creation of intrascleral veins or collecting lymphatics. You can see that 9 months after the surgery, if you inject ferritin blue, you can see that in the sclera there is blue color everywhere, and this is an infiltration of aqueous humor in the sclera, and this is the intrascleral bleb. So this is my first patient I did 30 years ago on the left with a very diffuse bleb. It's almost if there is no bleb, but the pressure is 12, 30 years later, because the bleb is inside the sclera and in the subchoroidal space level. Now, if you want to penetrate, and that is probably the way you should go here in India, because the antechambers are not so deep. So the first part is the same, and I'm going to skip this, and we're going to go directly to the penetration part. I'll try to go forward. I'm not able to do it. I'm sorry. Okay, I'm sorry. So what you do when you reach your deep dissection, just before starting to dissect between the sclera and the anterior trabeculum, you just open that. I really try to go, because we're just losing our time here. Now I'll go to another slide. Yeah, this is, you see better here. So now the iris is prolapsing. You just cut the iris. You have your deep sclerectomy. You put the iris, and then you have to close very tightly. I'm putting usually 8 sutures, 1 in each corner, and then 2 sutures on each side. It makes a total of 8 sutures. And then you have to inject viscoelastic. I'm using, in Switzerland, Elaflow, which is reticulated hyaluronic acid. I don't know if you get it here. And when I'm in Africa, I'm using methylcellulose, which is very cheap, and I'm filling not only the intravascular space, but the entire chamber. So the iris will take the good place, and then the chamber is full, and you have a pressure of about 20. This methylcellulose will go away after 1, maximum 2 days. So to conclude, in deep hysterectomy, if you do it non-penetrating or penetrating, you get an intravascular bleb, and that will help you, help your patient. You get a subchoroidal space, so you will enhance eurovascular outflow, and this will reduce the subconjunctival bleb, which will enhance the patient's comfort. It's ideal for children. It's ideal for patients with poor follow-up, because you don't need to follow them so much, because you don't need to do goniopuncture. I'm speaking about penetrating deep hysterectomy. And it's also ideal in young patients with a lot of physical activity to prevent iris incarceration. So thank you for your attention.
Thank you, Professor Andrew. And he is the innovator of the NPGS, for your information. And you must have seen that how beautiful dissection he did. I have never seen such a beautiful dissection. Thank you very much.
That's what we were